Yes, direct vision I already used in 1999 for epiuroscopies. And for epiuroscopy, some fiber optics were developed. And there was a company in Germany. And these are the hands. These are the hands of the CEO of that company. It was Polydiagnostic. There I'm not familiar with this kind of technology and fiber optics and the possible potential use with the technology advancing much more. We could make fiber optics, not me, that I'm not involved, but fiber optics could be obtained that would go through a small camera. So as you see, it all starts a little bit difficult maybe because I was there as an anesthesiologist when they did the first laparoscopies for sterilization. And now they are doing total colectomies and you name it with scopic procedures. So this is a development in the ultrasound. And now I say it's ultrasound with endoscopy, so use it. And the former speakers, they have pointed out exactly what are the good reasons to do this. It's an add-on. This you already saw. So this is the Eventide 7-star. It is basically a very simple system, easy to use. Upload, for example. So, in many cases it could replace the CR, which is of great value because it's not easy to have the whole hospital setting with radiation, protection, etc. going to the theater. So you could use ultrasound now more safely in the outpatient clinic. There are some developments, of course, new for different approaches we use, and there are developed different cannulas. This is some detail you can see here a line. Normally, when you go in the dense tissue, for example, the muscle, you can imagine that the tissue might enter into your needle, and that gives a blurred vision. So we use this in some occasions to have saline infused a little bit, only 2 mils an hour. It's just to keep the pressure in the cannula, that to prevent the tissue coming in. It's expanding fluid also, because you have to look forward. Applications is the added value also. It's not only replacing the CI, but of course you cannot with ultrasound, you cannot do any treatment. Now here see this is Professor List, already showed us yesterday. Very nice intraforaminal approach. Here we see the intercostal nerve, for example. Easy to approach. Here is the nerve. You can see the longitudinal artery on the nerve. So, paravertebral blocks. Doesn't work. Okay, just leave it. It's time, but you can see the blur, and of course, it will prevent that you get some trouble with the limb collapsing. Sciatic approach. This is in the cadaver. Also, celiac plexus block. You can see it here. You see the celiac artery. Of course, you need to recognize the picture. So but it is a steep learning curve. This you see already from Professor Chai this morning. This stellate ganglion block. And you see what is happening. If you go into the ganglion, you don't see what you expect, 3 branches. But what you can do is, next to the fiber optic, you can use a stimulating RF probe. And with the direct vision, you can, let's say, see if this is connected to the first branch, the second branch, or the third branch. So you can put a stimulating procedure. You need a little bit outer side cannula, about 18 gauge. So for the patient it is a little bit less, maybe a little bit more uncomfortable, and you have to anesthetize it more. This is when I put in a catheter epidurally. This is the very diamond-like epidural fat. And I tell you, when you do, for example, giving birth, we use the catheter, yes, without direct vision. But there is always a risk that the veins who are dilated because of the birth of the child, that you puncture that. And when you go to the theater for thoracic surgery, 4 out of 5 thoracic epidural injections are okay in experienced hands, but there is always 1 out of 5 that, although the doctor says it's very accurate, it isn't fit. You don't even use the loss of pressure. You know, you loss of resistance, you don't need. You just advance the needle, and this diamond-like fat will enter. When you see just a white thing, that is the ligamentum flavum, and then you push forward, and and this will come into your needle, and you can see it, then you are there. So it's a totally other concept. Let me sit back to me. This is a little bit difficult to interpret, to see the lumbar sympathetic. It is somewhere here. Here it is. But I couldn't let's say, take the image of the ganglion. Yesterday I showed you the cordotomy. You don't have to use saline in the cordotomy because you have the cerebrospinal fluid, so you can see it very well. It's for single-sided cancer pain, cutting the spinal thalamic tract, which is still a little bit, doctors are reluctant to do this because it's a spinal cord lesion, what you are, in fact, produce. Because the spinal thalamic tract is in front of the dentate ligament, on the ventral side. If you go here with your RF probe, then you have a paralyzed patient. So you don't want to be motoric. And this is what you actually see. Here is the probe, the RF probe. These are the radix radici, the ventral root entrance on the spinal cord. Here is the dentate ligament. You want to be on the ventral side, on this side. And here you see it in real time. You see the pulsating of the heart. You see a little clot here, with the pulse of the heart going up and down. This is the electrode. Here is the dentate ligament. And now I withdraw the needle after 20 seconds or so. You see a small hole in the needle. And then you do the normal testing. Tracheotomy, for example. We lost a few patients in the Netherlands during the COVID period by accidental, incidental deintubation in the overcrowded ICU unit. And then you have to do an emergency tracheotomy, and you have a default route. The patient is already, swollen, and it could be very difficult. So with this technology, you just push it between the cricoid, thyroid, and you see the tracheal rings. You put in the guide wire, dilate that, put in your device. Have to go through. It's also used, of course, in the outpatient clinic. It is easy for orthopedics. That's another discipline. That they use it just to diagnose and to put some small treatments into patients. Without, of course, radiology, without CR. This is urologist. Diagnosing, using it for kidney, for biopsies, but also on the liver. If you have a carcinoma, it's very small metastasis, which is more, then it's difficult to see on the ultrasound, where you exactly can do your biopsy. So new horizons. Already the former speakers, increased accuracy, safety of injections, procedures, maybe better outcomes, provides the invisibility and accuracy of ultrasound, guided procedure, no syndrome radiation, and it's cost effective because you don't have to use the whole hospital setting. And of course, forensic, you can record actually what you are doing, which is very important that when there is any claim or any complication and the patient may, you can also show where you were and what you have done. So this is, I think, the future. And I hope we really are going to use it. Thank you.